Bismillahirrahmanirrahim. The deficiency of vitamin D and resultant pathologies are discussed in this video. So, vitamin D deficiency will result in rickets in children. So, rickets is a disease of children caused primarily by calcium or phosphate deficiency in extracellular fluid, usually due to deficiency of vitamin D, and it leads to defective bone mineralization and skeletal deformities. The main cause of this rickets is lack of vitamin D. Without vitamin D, the calcium and phosphate absorption from the intestine is impaired. This vitamin D is can be synthesized in the skin when 7-dehydrocholesterol is activated by ultraviolet rays from sunlight. So if there is low sunlight exposure, or the children who are staying indoor during the winter, they lack this ultraviolet light exposure, they they may develop the disease. So there are seasonal effect. This disease tend to occur in spring. In the summer, sunlight builds liver stores of vitamin D, and during winter there is depletion due to indoor activities, and this depletion occur gradually, and by spring stores are exhausted, revealing deficiency. So there is early compensation by calcium and phosphate mobilization from the bone, and this initially prevent clinical signs of the rickets despite vitamin D deficiency. So there is parathyroid hormone response, and this parathyroid hormone response prevent the plasma calcium from dropping significantly by stimulating bone resorption. So there is no strong phosphate regulation. So phosphate, it is steadily decreased. So in the laboratory, the calcium plasma calcium level is slightly decreased or near normal due to the parathyroid hormone effect, while the plasma phosphate is markedly decreased due to increased urinary phosphate excretion under the parathyroid hormone effect. So there is weakening of the bone in the rickets. So there is a low calcium and phosphate availability due to vitamin D deficiency. So there is compensatory increase in parathyroid hormone or a secondary hyperparathyroidism. That will result in increased osteoclastic resorption of the bone to maintain the calcium level in the plasma, and this there is also decreased mineral content of the bone over time. So there is a process of weakening of the bone. So there is excess bone resorption because this parathyroid hormone stimulates osteoclastic activity that will result in breakdown of existing bone mineral matrix, and weakening of the bone are is there due to this activity of the osteoclasts, and these bones are now more vulnerable to mechanical forces. So there is also osteoblastic response due to this marked physical stress, and osteoblasts, they try to compensate by producing osteoids, that is unmineralized bone matrix, but so the large quantities of the osteoids are formed, but newly produced osteoids remain uncalcified due to non-availability of the calcium ion and phosphate ion. The result is the bone that is weak, soft, and poorly supportive of weight and mechanical load. So replacement of old mineralized bone with new one but uncalcified osteoid lead to progressive skeletal deformity and structural weakness. So vitamin D deficiency can be caused by low sunlight exposure or dietary deficiency, or there is a defective conversion or no conversion of this vitamin D into 125 dihydroxycholecalciferol. So this will result in decrease in intestinal absorption of calcium and phosphate, and there will be due to these defects there will be changes in the blood chemistry. So the calcium uh, is slightly decreased because the calcium concentration is tightly regulated by the parathyroid hormone to compensate, and the phosphates are significantly decreased because of the increased renal excretion due to the effect of the parathyroid hormone. And if this defect of the vitamin D is prolonged and the resultant parathyroid activity is prolonged, there will be increased osteoclastic activity that will lead to reabsorption of the bone. Simultaneously, there is increased osteoblastic activity that will result in osteoid formation, and there due to low calcium and phosphate, these osteoids are not calcified. So, due to lack of mineralization, there is formation of weak and soft bones, and clinically this will result in deformities, fracture, bow legs, and knock knees. So tetany is one of the clinical condition that occurs due to this rickets. There is vitamin D deficiency with impaired bone mineralization. So after prolonged bone resorption, there is calcium depletion, and in the early phases, there is no tetany because of the effect of the parathyroid hormone that stimulates the osteoclastic bone resorption, and this mechanism almost regularize the extracellular calcium level despite the deficiency of the calcium. And then there is progression to the late stages, and in the late stages, the bone calciums are now exhausted and they are unable to maintain the normal calcium level via the resorption of the bone. And the calcium extracellular fluid concentration drops significantly, and the critical calcium threshold that is required for the development of tetany is less than 7 milligram per deciliter, that will result in neuromuscular hyperexcitability. So the muscle spasm will result, and the most dangerous, as we have already seen, is laryngeal muscle spasm that will lead to the airway obstruction. So without intervention, it may lead to death. An immediate form of treatment is intravenous calcium administration that will result in rapid relief of the tetany. So large amount of the calcium and phosphates should be given in the diet, and vitamin D for the absorption of these calcium and phosphate is necessary to administer. So if the rickets is diagnosed, correct the mineral deficiency immediately and administer large doses of vitamin D to increase their absorption, and this will lead to increased absorption of the calcium and phosphate and restore the mineralization of the bone. Osteomalacia is adult equivalent of rickets. It is softening of the bone due to inadequate mineralization, and it is rare in adults due to lower calcium needs for the bone growth. There is steatorrhea, that is the failure of absorption of the fat, and this will lead to the loss of calcium and vitamin D, that are the fat soluble vitamin, and this will result in deficiency, and calcium forms insoluble soaps with the fat, so there will be poor calcium absorption. Both vitamin D and calcium, they pass into the feces, so there will be deficiency. So their effect is that the poor calcium and phosphate absorption and resultant bone weakness. Usually no tetany is developed in the adults and can lead to severe bone disability. Then osteomalacia and rickets are associated. The causes of renal rickets is usually prolonged kidney damage, and this damaged kidney failed to produce 125 dihydroxycholecalciferol, that is the active form of the vitamin D, and it is common in patients with kidney removal or destruction, especially in hemodialysis. One condition is congenital hypophosphatemia. This congenitally reduced phosphate resorption in the renal tubule leads to low plasma phosphate that will result in poor bone mineralization. So in prolonged kidney damage, calcium and vitamin D is given, and in congenital hypophosphatemia, phosphate compounds with vitamin D, because phosphate compounds are given, and this is also called as vitamin D resistance ticket, because administration of vitamin D is not going to correct the situation. Osteoporosis is most common bone disease in the adults, especially elderly. It is distinct from osteomalacia and rickets. Osteomalacia is diminished organic bone matrix. So osteomalacia and rickets, there is defective calcification or mineralization of the bone matrix. The primary issue in the osteoporosis is decreased osteoblastic activity. There is decreased osteoblastic activity that will lead to the decreased rate of osteoid production in the bone. As a result, there is deposition is decreased. So occasionally increased osteoclastic activity is also associated with this osteoporosis, as is seen in hyperparathyroidism. Common causes of osteoporosis are lack of physical activity or inactivity of the person. So mechanical loading is not there, because mechanical loading stimulates the bone deposition. So in the absence of mechanical stress, the bone resorption dominates. Then there is malnutrition. So inadequate protein intake will lead to insufficient collagen or osteoid formation. Vitamin C deficiency is also one of other cause of this osteoporosis, because vitamin C is essential for the collagen synthesis, and deficiency impairs the osteoid formation. So menopause is associated with osteoporosis because estrogen normally decreases the number and activity of osteoclasts, so lack of the estrogen will result in increased bone resorption. In old age, due to cellular senescence, there is decreased growth hormone and growth factors. Then there will be decline in anabolic functions that will lead to the less protein deposition in the bone. Cushing syndrome is another cause of osteoporosis, that is the glucocorticoid excess. So due to increased glucocorticoids, the protein deposition is decreased and increased protein catabolism is there, that will directly suppress the osteoblastic function. So any disease or condition causing protein metabolism deficiency can lead to osteoporosis.